So the topic today is Rhesus isoimmunization. I think we all agree, both midwives and doctors here, that you know that you should be testing for Rhesus. So today we'll try to explain the reasons why Rhesus should be tested for, and also how to manage those who are Rhesus negative, so that they say so that they don't get sensitized, and also how to manage those who have been sensitized. It is, let me say, it is the task of the fetal medicine unit to manage women who have been sensitized, who are Rhesus negative and been sensitized. So it is important that all of us are well versed with the approach to the management of women who are Rhesus negative and sensitized. So just to give you the background, this is the background here. You can see that in 1609, the French midwife reported on a hemolytic disease of the newborn in a set of twins. Then in 1932, Diamond and colleagues described what was later called erythroblastosis fetalis. It's all the same thing. Then in 1940, Lensteiner and Venner discovered the Rhesus blood group system. Then in 1953, Shaw confirmed pathogenesis of Rhesus alloimmunization. Then in 1966, that's when the anti-D immunoglobulin G prophylaxis was demonstrated by two groups in UK and the US. Then in 1971, WHO technical group recommended 25 micrograms or 125 international units IM per 1 ml of fetal hemorrhage or 2 ml of whole blood. So this is when the anti-D immunoglobulin started. Now, the prophylaxis for women who are Rhesus D negative and who have been put at risk of sensitization from sensitizing events. So in terms of the pathophysiology, we should know that there are many blood groups, more than 15. The next bullet just highlights some of them. We know the ABO that we are probably very familiar with. And we have the Rhesus blood group, the KO, the ML, the P, the Lewis, the Lutheran, the XGYT, Dombrock, Colton, public antigens, and private antigens. There are many of them. So whenever we are testing for antibodies, we normally say test for the Rhesus and the atypical antibodies. Atypical, we're including this whole group. There are certain individuals with their own unique antigens. Probably before I go further, the question is, what are the antigens? The antigens, these are the skin covers, what covers the red blood cells, the coat on the red blood cells, the identity of that coat. If we are saying the woman is Rhesus positive, we are saying they have the Rhesus coat on their red blood cells. If we are saying they are Rhesus negative, they do not have this coat on the red blood cells. In other words, it is an identity which allows cells to be identified as they circulate within the mother's bloodstream, so that if a woman who is Rhesus negative receives the blood, any blood which is Rhesus positive, the immune system of that woman is bound to identify that those red blood cells as foreign agents, and the body will mount an immune response. So this is how antigens work. When we are saying ABO is the same language to say we are saying this is what is covering the red blood cells, skin. Then the blood group antigens appear by 40 days of intrauterine life. So we're saying around the 7th week, the baby's red blood cells now have this skin covering. Either the baby could be Rhesus positive or could be Rhesus negative. So this is how early the Rhesus system appears in babies. So as early as the 7th week, okay, 6th week, end of the 6th week, right? End of the 6th week. So remember this, very important, so that you know why we can start monitoring for evidence of Rhesus isoimmunization as early as 16 weeks. Most of these have been associated with hemolytic disease of the with hemolytic disease. However, ABO and Rhesus account for more than 98% of hemolytic diseases. I mean these antigens on top here, that most of the hemolytic diseases are due to either ABO and Rhesus. This is why we're going to be talking about Rhesus. The ABO doesn't contribute much in fetuses. So this is why we're not going to be talking much about the ABO, because the ABO antibodies normally do not cross over to the mother because of their size. So we tend to get more of the Rhesus issues. So in terms of the blood, just calling the blood antigens, normally whenever there is exposure, the first antibodies to be formed are called the allo antibodies or agglutinins, which are natural, the IgM antibodies, which are found, which are more like the primary immune response antibodies. So the IgM, these are formed against the major antigens, which are present in all individuals when the antigen is absent. Then in most other minor systems, the other antigens, which I told you, natural antibodies to the antigens are found occasionally, but as their antigenicity is low, the immune antibodies are also rare. So this is why the KL and the DAF, they normally don't give problems. They rarely give problems. Then the antigens themselves, they react poorly at body temperature, except the anti-A and anti-B, but agglutinate red blood cells at 5 to 20 degrees and usually do not cross the placenta. This is for the rare types. Then the isoimmune antibodies, these are the IgG. These are formed in response to foreign red blood cells or soluble blood group substance. They readily cross the placenta. Hence, these pose a risk to the baby. The IgG, I'll explain the importance why you have to understand the IgM, the IgG. Then most antibodies are complement binding, notably exceptions being Rhesus and the MN antigen type. The following antibodies, the following are the alloimmune antibodies that cause severe hemolytic disease of the newborn. We have the Rhesus, the KL, the DAFI, the KID, and the MNS. Today we're talking mainly about the Rhesus, so just remember that. So the Rhesus blood group system is the Fisher nomenclature. The Rhesus gene complex consists of 3 genetic loci, each with 2 major alleles. They code for 5 major antigens, that is the C, C, E, and D. Rhesus blood group antigens are inherited as determined by at least 2 homologous but distinct membrane proteins. 2 separate genes located on the short arm of chromosome 1 encode Rhesus protein, and each gene is 10 exons in length, and the 96 homology between these genes is observed. What is this slide telling us? It is just telling us that the gene consists of 3 genetic loci, and whenever it is reported, when we do laboratory testing, it is reported showing all these genes, so that when you read the reports of the laboratory, you shouldn't be worried or concerned to say, why are they reporting like this? And these are the 8 gene complexes which are possible in the Rhesus. So you can see that these are the different kinds of gene complexes. And when the reports come, they come like this, depending on what the patient has. The expression is limited to red blood cells with an increased density during their maturation. So you do not find these antigens in any other tissue except the red blood cells. And the density increases as the red blood cells mature. Unlike the ABO system, which exists in a wide variety of tissues, This is the difference between them, and the Rhesus antigen is not expressed on red blood cells progenitors. Progenitors, we are saying the cells that form the red blood cells, like erythroblasts and so forth, and the erythrocytes, before they become fully functional red blood cells. So we do not find these antigens, the Rhesus antigens, on them. Then for Rhesus positive individuals, 45% are homozygous. What do you mean by homozygous? That means both alleles they are coding for the Rhesus gene. Then 55% they are heterozygous. Heterozygous means one of the allele is coding for the Rhesus gene, but because it's a autosomal dominant, the individual will be referred as to Rhesus positive. What is the implication of this? The implication of this is that if we have a Rhesus positive husband, a husband who is known to be Rhesus positive, and a mother who is known to be Rhesus negative, if the father is homozygous, which means the chances that they will have a baby who is Rhesus positive is almost close to 100%. While if the father is heterozygous, using the Mendelian inheritance pattern, it means the chance is around 50%. This is very important. This is why sometimes before the era of the fetal self-DNA test, determining the actual gene, whether the husband is homozygous or heterozygous for Rhesus positive, was key in the management of Rhesus negative women. But now in the era of fetal self-DNA tests, the best thing to do is just know the baby's Rhesus status, and that will be the end of the story, really. Yeah, because all these tests were trying to predict what the baby's Rhesus status is. Mutations and rearrangement can lead to lack of expression of Rhesus D phenotype. So sometimes the baby may inherit Rhesus D positive genes from the parents, but mutations and rearrangement may mean that the antigen won't form, and there will be no expression of this antigen. So this is a case whereby you are having a Rhesus positive child, but there is no risk for the mother to be sensitized. I mean, a potentially child from a Rhesus positive father who is homozygous, but there is no risk of isoimmunization on the part of the mother. So remember, mutations and the rearrangement. This is very important, because you could have very weird scenarios where some parents may say, look, I'm Rhesus positive homozygous, why is my child not showing the Rhesus positive antigen? So this should be made away. If there are challenges, I mean, if there are issues, then probably genetic testing has to be done, because this could also be interpreted as meaning wrong paternity by some people. So just be aware of it. It's very important. Rhesus blood group system. Then in terms of I think I've already said this, so I will skip this slide and probably this one as well. Yeah. Then, right, maybe let's come here. Then in terms of the incidence of Rhesus negative, it varies in different races. Mongoloids, they have new Rhesus negative people amongst them, while the Chinese and Japanese is about 1 to 2%, Indians is about 5%, Africans is reported around 5 to 8% of women, of people who are Rhesus negative. In our country, the data we have is an extrapolation from pregnant women, where it is around 3% there. That's where it is in our country. So it's about 3% of us are Rhesus negative. Caucasians, it's about 15%, and Basques are people found in the region of Spain. They are about 30 to 35%. You can see that the incidence of Rhesus negative status varies by race and also geography. The antigen expression of these genes are dependent on the interaction between red blood cell membrane protein and phospholipid molecule result in a set of anti-elliptical epitopes. The corresponding antigen controls CC or DD or E. The antigen determinants form an intrinsic part of the red cell membrane protein structure. Where am I? Okay, we are here now. The CC and E are weak antigens and impractical to match. The D is by far the most immunogenic in the Rhesus system, except those that have the natural antibodies. There's a rare type of Rhesus negative called Rhesus now, which lack all known Rhesus antigen. D antigen have no natural antibody, while C and E have the corresponding natural antibodies, though weak and found infrequently. A single transfusion of positive blood to a negative person has a 50% chance of forming anti-D antibodies. So the chance is not 100%. It's very important to understand this, that if you give somebody Rhesus B positive blood, if they are Rhesus negative, it's not automatic that they are going to form the antibodies. Then the chances of transplacental hemorrhage or fetal maternal hemorrhage are only 5% in the first trimester, but 47% in the third trimester. Many conditions can increase the risk. Why is this statement important? It's important in the fact that when we are giving anti-D, we try to give it in the third trimester, not in the first trimester, because that's when the chances of hemorrhages are high and the chance of sensitization are high. Then the chances of primary sensitization during the first trimester is only 1 to 2%, but it is 10 to 15%, but 10 to 50% of patients may become sensitized after delivery. So the woman is not safe even after delivery if we don't follow the protocol for managing these patients. The protocol is to be followed. ABO incompatibility and Rhesus non-responder status have been known to protect from possible sensitization. The amount of antibody that enter the fetal circulation determines the degree of hemolysis. So this is where the word titer comes in. The titer will be telling us about the concentration of antibodies within the mother, with the mother's bloodstream. The higher the concentration of the antibodies within the mother bloodstream, the higher the chances of more antibodies crossing over to the fetus to cause hemolysis. I'll be explaining through a table just now. So what happens if we have a Rhesus negative woman and a Rhesus positive man? If the man is either homo or heterozygous, if the man is heterozygous, there is a chance that the couple could have a baby who is Rhesus negative. In this case, no problem. Nobody is in danger here, and that's the end of the story. This pregnancy does not need to follow up. If we prove that the fetus is Rhesus negative, either by doing a fetus-free DNA test from 10 weeks, then our story ends here. This is now just a normal pregnancy. It should be looked after in a routine way. Then if it happens that the baby is Rhesus positive, and there are what we call sensitizing events, which I will show you just now, then there is a good chance that the baby's red blood cells will cross into the mother, and these cells are going to stimulate what we call a primary immune response to this non-sensitized mother. So the primary immune response will produce the IgM antibodies. These IgM antibodies do not cross the placenta, hence the baby is unaffected and the baby escapes. So this is what happens to first pregnancies of this couple, of this kind of a couple. So the first baby is not going to be affected, but the mother will have been sensitized. So if the mother happens to have another baby who is Rhesus positive in a second pregnancy, what is going to happen is that the body is going to mount what we call a secondary immune response, which will produce the IgG antibodies. The IgG are smaller molecules compared to the IgM. The IgM are pentameric, which means there are 5 molecules around the center, while the IgG is just a single molecule. And these are small molecules that can cross the placenta. So the antibodies are going to cross the placenta and attack the fetus as red blood cells and make them agglutinate and cause hemolysis. They'll be broken down in the reticulocyte system. As they pass through the spleen and so forth, they'll be broken down because they are too big to pass through the filters. So the red blood cells will be damaged, hemolysis. When that hemolysis happens in the uterus, the baby is going to develop anemia. Anemia will cause the baby to respond in a way to try and compensate by activating the secondary erythropoiesis centers like the liver. The liver very early in pregnancy acts as an erythropoiesis center, means it forms red blood cells. So there's going to be erythropoiesis, hepatic erythropoiesis is going to increase, which will cause dysfunction in the liver, and there's going to be compression of the portal and the umbilical vein, causing fetal hypertension, leading to heart failure. This is the immune hydrops come about. This is the third dispersing of fluid you see on scan, where you say the baby is ascites, is pleural effusion, and the heart looks dilated. This is how it comes about. The excess bilirubin is not a factor in uterus because the maternal liver will take care of it. Compared to the adult, it's a tiny amount, whatever is coming from the fetus, and the maternal liver will break it down. But for a baby after birth, the excess, because the process of destruction may continue after birth for a while, and this will cause jaundice due to hyperbilirubinemia, kernicterus, and the baby may have suffered a hepatic failure at the time of delivery, and the baby will die. The same condition is the one which was called erythroblastosis fetalis, when the baby is now swollen with fluid everywhere. We now call it hydrops fetalis instead of erythroblastosis fetalis. Hydrops fetalis, and this will lead to intrauterine fetal demise. So, yeah, this is a very dangerous condition if undiagnosed and feel allowed to, the natural process is allowed to occur. Right. Now, we have described more of the pathophysiological process, a little bit of the genetics of it, the immunology of it. Now, let's go to the clinical application to say, what do we do when we see a Rhesus negative woman? And this woman will either wants to be pregnant or she is pregnant. Well, how should we manage it? Of course, if you are for women who probably has been sensitized, let's assume that a woman was given wrong blood transfusion after an RTA, or probably for one reason or another, she is sensitized and she wants to get married. She has antibodies already. The most ambitious plan is to for her to go for premarital counseling and choose a man who is Rhesus negative. But it's very ambitious, of course. But if you are living in the Baltic region, where 45% of people are Rhesus negative, certainly this should be practical. I mean, you will find someone, was almost half of the population. It should be easy. But Hi guys, I hope I'm back to all of you. I dropped out. So let me continue. So Rhesus, it is to be a national, it's still a national policy to assess the Rhesus status of every woman, but we are aware that this is not happening routinely because of resources. So this will put us at risk of having women sensitized because people don't know their Rhesus status nowadays, especially in the public sector. Then every woman should have their blood group known, the Rhesus status. Most of in the private sector, where women have to pay for the test, you can afford to pay for the test. It would be unfair for you not to check the woman's Rhesus status. Then if the woman happens to get Rhesus positive blood transfusion, then 300 micrograms of immunoglobulin should be given. The actual quantity should be calculated. It's not the 300 microgram, but anti-D immunoglobulin should be given to these women. Then proper management of unsensitized Rhesus negative pregnancies is necessary. I'll go to that page now to say how then do we manage Rhesus unsensitized pregnant women. Probably before I go there, these are some of the incidence and volume of fetal maternal transfusion pregnancy that can occur in pregnancy. You can see that in 54% of the pregnancy, there is some hemorrhage that may happen across, and the volume is very tiny, about 0.07. In second trimester, in 63%, 0.08. Third trimester 0.13 and delivery 0.1. You can see that the amount is increasing with gestational age there with the trimester. So be aware of that. Then these are the what I would call sensitizing events that have got the potential to sensitize a woman who is Rhesus negative, who is potentially carrying a Rhesus positive baby. So early pregnancy loss, elective abortion, ectopic pregnancy, amniocentesis, coronary villus sampling, chondrocentesis, antepartum hemorrhage, placenta abruption, fetal demise, manual placenta extraction, and external version. So all these events, because they have a potential to sensitize or to cause the woman to form antibodies, anti-D immunoglobulin should be administered after the performance of these procedures. Right, then management of unsensitized pregnancy. A woman comes to you, she's unsensitized. How should we manage her? First of all, we want to do blood typing at her first visit. If negative, the husband should be done. But however, there is, sometimes you unravel the things that you don't intend to unravel when you have the habit of testing all husbands, because sometimes the husbands may not be the father. That's the other tricky part of it. So it's a little bit tricky. So you can still test the husband. If he's negative, blindly you can assume that the baby is not at risk, but sometimes you may be wrong. However, in this era, I know this is not available in the public sector, but I want you to be aware that in the private sector, you can consider to do NIPT from 10 weeks. The NIPT will allow us to know the baby's Rhesus status, so that we can save the woman from getting the jabs, or save ourselves from unraveling certain things that we don't intend to. Then if husband is positive, if possible, know whether they are homo or heterozygous. This is before the era of NIPT, or in women who cannot afford the NIPT. Then in that case, you have to do indirect Coombs test of the mother. What is indirect Coombs test? Indirect Coombs test is trying to check if the mother already has antibodies against the Rhesus D positive red blood cells. So if you do that test and the mother is negative, then that is a good thing. The pregnancy goes on, and you will check again later on to check for any evidence of sensitization. Or if the woman has any sensitizing events, you may need to check again. Then we repeat the indirect Coombs test at 28 weeks. If negative, we repeat it 35 weeks. then if it is negative, then we don't have to do anything. However, if positive, or there is evidence that they've been sensitized, we don't give 300 micrograms. The woman is already sensitized. In cases of abortion or miscarriage or ectopic pregnancy or any process or any of the other sensitizing events, if it is the pregnancy less than 12 weeks, 50 micrograms should suffice of anti-immunoglobulin. But if they are more than 12 weeks, then they need 300 micrograms of anti-immunoglobulin to try and neutralize the formation of antibodies. Then if there is any of the events there, the fetal maternal hemorrhage, amnesty, abdominal trauma, again, APH, intrauterine fetal demise, 300 micrograms anti-immunoglobulin. At birth, cord blood for A, B, O, and Rhesus typing should be taken. Then if the baby is Rhesus negative, we are happy. But if at birth, the baby is Rhesus positive, then the mother's blood should be taken for indirect Coombs test, and the babies should be taken for direct Coombs test. What is direct Coombs test? Direct Coombs test is trying to check if they are red blood cells that are already attached together by antibodies, right? So we're trying to look and see if they are already red blood cells that have already been attacked or agglutinated together by the antibodies. So that's the direct Coombs test. That's what we do on the fetus. The indirect Coombs test is to look for antibodies within the mother's bloodstream. While the direct Coombs test, we're now looking for evidence that the red blood cells of the baby already been attacked. If negative, of course, if the ICT or the indirect Coombs test is negative or weakly reactive, we give 300 micrograms of immunoglobulin. If positive, then sensitization is already occurred. We need to check the hemoglobin and the bilirubin estimation of the infant, and the infant is treated by the pediatricians. Then for women who prove that they are not sensitized, we should give them anti-D immunoglobulin at 28 weeks, from 26 weeks, 34, and at birth. So 34 and at birth, that's when you should start. 26 to 28 weeks is still fine, but it should be 6 weeks apart, roughly, because of the time it takes for the immunoglobulin to disappear from the mother's stream, its bloodstream. Then what about those who are sensitized? How should we then manage them? If there is evidence that the woman is sensitized, first of all, we should think of the cause of sensitization to say what could have caused it. Misinterpretation of the mother's Rhesus type. For example, if the test reports wrong, let's say the woman is Rhesus positive when she is actually negative, then Rhesus positive blood transfusion. This does okay sometimes. I remember as a junior, we had to do this to try and save women's lives, where we just took all positive blood without even typing the woman because we wanted to save their lives. If the woman were Rhesus negative, we potentially could have sensitized them. Then unprotected pregnancy and labor, that means if we don't give anti-D immunoglobulin to women who are Rhesus negative, we're going to potentially sensitize them. Then inadequate dose or improper use of immunoglobulin G on previous occasions. So if we give less dose than the fetal maternal hemorrhage amount that is occurred, we are likely to sensitize them. Then immunization to cross-reacting antigens can also cause this. Then the pregnancy itself, how should you manage it? Of course, there is need for careful planning. The whole pregnancy care plan should be laid bare before the patient to say what are we going to do during the antenatal period, the intrapartum, and the neonatal period. The father's blood group type and the Rhesus antigen status should be known. This is very important because sometimes people change husbands. Even if they were sensitized, they could have married probably a husband who is Rhesus negative and their baby would be Rhesus negative. In that case, they are fine. But in our modern era, it's always good to do the NIPT for fetal Rhesus. so that we know the actual blood group of the baby. If the baby is Rhesus negative, then that's the end of the story. Even if the woman has got antibodies, the baby will not be attacked because there is no antigen on the baby's cells. But if the baby is Rhesus positive, the story continues now. And say, now we need to know the titer, the antibody titer, so that we can monitor for the critical level. What is the antibody titer? The antibody titer, we are looking at the concentration of the antibodies within the mother's bloodstream. The higher the concentration of the antibodies, the higher the chances of isoimmunization on the part of the baby. So intrauterine fetal monitoring with MCA, sorry, that's MCA, not MCS, it's my mistake. With the mid-cerebral artery peak systolic velocity Doppler is recommended for women who have reached what we call the critical titer level. I'll explain a little bit more about the titer. Let me just do a little bit on anti-immunoglobulin here. So the antibodies are extracted by cold alcohol fractionation and outer infiltration of plasma containing high titer D antibodies. The half-life is about 24 days and persists for only 6 weeks. This is why our jab interval is about 6 weeks apart. So remember this. 300 micrograms will protect from fetal maternal hemorrhage of up to 15 mils of D positive red cells and 30 mils of whole blood. So this 300 micrograms is quite good. I mean, it covers quite an amount. It is rare for a woman to have 15 mils of fetal blood. I mean, being transfused to them, or 30 mils, that's a lot. Most women don't get to that part. The initial dose produces a weekly positive response of indirect Coombs titer on the mother. Adequate dose is demonstrated by a positive indirect Coombs test. So ideally, whenever it is given, it is always good to do the titer to see if the woman is responding to it or not. Then the Clay-Beckett test, what is it? This is an acid elution principle where it is known that hemoglobin F is more resistant to acid elution than hemoglobin A. Hemoglobin F means fetal hemoglobin. It is different from hemoglobin A, which is found in adults. It will transition after birth or towards birth. Hemoglobin F can be identified by uptake of a special stain and quantified on peripheral smear. The quantity of fetal maternal hemorrhage formula to say how much bleeding or how much of the fetal blood has gone into the maternal circulation. This will allow us to calculate the amount of anti-D immunoglobulin to give, so that we know if 300 micrograms is enough or is not enough. So fetal blood volume is equal to maternal blood volume, which is normally around 5 to 6. It increases in pregnancy, maybe to around 6, between 6 and 7.5, times maternal hematocrit, times percentage of fetal cells in Clay-Beckett versus the newborn hematocrit. So this is used to calculate the amount of fetal maternal hemorrhage, to say how much fetal maternal hemorrhage happened, for you to know how much to give. It's normally done around the time of birth because you can't get all these indices in uterus. So this will allow people to calculate the amount of anti-D immunoglobulin to give. But like I said, it's very rare to exceed 30 mils of fetal maternal hemorrhage, even a delivery. So 300 milligrams suffices in most cases, and very few people are doing this test anymore. Then the mid-cerebral artery, this is a non-invasive method used to predict fetal anemia. The anemic fetus shunts blood preferentially to the brain to maintain adequate oxygenation. This response can be identified by measuring peak blood flow velocity in the mid-cerebral artery. If mid-cerebral artery peak blood flow indicates that the fetus is likely to be anemic, further evaluation is appropriate. So this is how we do it. You are all well versed with doing MCA. So that's the MCA, as you can see there. We use the perinatology website to input our peak systolic velocity. Then we do calculate and we get the multiples of median. Fetal anemia will correspond to an MCA PSV of greater than 1.5 multiples of median. So that's fetal anemia. These are features, eye drops. I think you are all aware of what we said with babies, eye drops, ascites, then the antibody titer. So the antibody titer, the serial antibody titers are done for IgG antibody positive cases. A titer above a critical level required for the evaluation. So the critical level, what is this critical level? The critical level is that level where the chances of isoimmunization is very high. We are saying if we go above that level, the chances are high. What is their clinical role or application of the antibody titer? The antibody titer will allow a person in Chicompedzi to monitor a rhesus negative woman by doing antibody titer where there is no ultrasound or skills to do a cerebral artery Doppler diagnosis fetal anemia. And they will refer the patient to a center that can diagnose fetal anemia when the antibody titer reaches a critical level. So where you do not have a center that can monitor for fetal anemia, then you can do antibody titers. Or if you want to triage patients in the fetal medicine and say which patient should be seen by a specialist, then we do antibody titers so that those with a low antibody titer can be seen in the routine clinic. So these are the critical values. So antibodies, the critical antibody titer is 1 in 16. While for anti-K is 1 in 8, for anti-C&E is 1 in 32. What is this 1 in 16? We are saying we have to dilute the maternal serum 16 times for us to neutralize the antibodies in there. So when you are saying 1 in 8, which means we have to dilute 8 times, which means it's less. When you are saying 1 in 4, which means you have to dilute it 8 times. But if you have to dilute it 32 times or 64 times, that just shows you the amount of antibodies that are in there, that there are too many of them, and you have to add more to dilute them. So understand this, the higher this value, the 16, 32, 64, the higher the concentration of the antibodies in the maternal serum, and the higher the chance that the baby will be isoimmunized. Fetal blood sampling is now done in the setting of transfusion. It's no longer being done to diagnose fetal anemia. So it's being done at the time of fetal intrauterine transfusion. Yeah, and these are the pregnancy loss rates, and yeah, these are some of the complications which I'll just flash there. Right. Then the intrauterine transfusion for preterm babies, very early intraperitoneal transfusion is the way to go because the vessels are too tiny. But later on, intraumbilical transfusion is the way to go, and is normally done at the site of the cord insertion, where it is where it is difficult to miss. It should be commenced when the HB is at least 2 grams per deciliter below the mean for normal fetuses of corresponding gestational age. Other recommend transfusion when the fetal hematocrit is below 30%, which is 2 standard deviation below the mean at all gestational age. On the Fetal Medicine Foundation website, there's actually an application that allows us to calculate the hemoglobin of the fetus once we put the PSV, so that you know roughly how much how anemic the baby is. So yeah, that can be done. In a brief, this is the presentation on Rhesus. So to just summarize, women who are Rhesus negative, we need to watch for sensitizing events so that they can get the anti-immunoglobulin jab at sensitizing event. If they have no sensitizing events, they should be given the anti-immunoglobulin at 26 weeks, 34, and at the time of delivery. For women who are sensitized and they are carrying a Rhesus positive woman, if we don't know the Rhesus positive baby, if we do not know the Rhesus status of the baby, we assume it's positive for sensitized women. And we monitor them by doing titers. And if they reach the critical level of the titers, then they have to be followed up in the fetal medicine unit where we will do the mid-cerebral peak systolic velocity to try and diagnose fetal anemia. I think in brief, this is it. I'll stop here. If there are any questions, urgent questions, I could answer them now. You can type in the group or even ask later in the group. Otherwise, thank you so much. Thank you so much. I think we are done if you don't have any further questions.